Thank you, Andrew, and welcome everyone. It's great to see so many friends of Opportunity Canada joining the call here this afternoon. And as always, thank you so much for making a little bit of time in your schedule to connect with us. And it's, I think, really important for us as a broader community to stay in touch, particularly as we are all stuck in our homes right now and trying to flatten the curve and stop the spread of this ridiculous virus. Just a couple of opening comments before I introduce our special guest today. As you all know, we are caught up in this COVID crisis like everyone else is around the world, and certainly is impacting operations here in Canada. Our team, I'm happy to report so far, is very safe, and there's no reports of any issues, but all of our team are wrestling with the broader challenges of family members that they're worried about. And so please do keep us in your prayers. But everyone is working very hard right now in this sort of new virtual model, which we're fairly comfortable working in any event, since we always do all of our meetings across the country by Zoom anyway. I did mention last week, and this is the third of 4 weekly town halls that we've scheduled as part of this COVID response. And last week we did announce that we'd launched our COVID-19 response fund. And really the whole point behind that is to quickly garner some resources so we can come alongside our partners. Our partners are in the middle of this, like we are, with each of their different challenges. As you know, we work through Microfinance Institute partners in the countries where we serve. And for the most part, they are considered essential services. They are open. They're open with reduced hours. Some of the branches are closed. In Honduras, they were actually closed for a couple of weeks, but are now reopening. But most of their clients are also affected by the shutdown, and many of them are not able to work. So there is, there are a number of challenges, as you can imagine, around that. Some of the clients at the bottom end of the ladder are really struggling even with meals, and some of our partners have been, dropping off groceries and providing excellent training on how to prevent the further spread of the virus and trying to get ahead of this as best they can. They're also already wrestling with what will this look like post-COVID. So what we're really doing now is we've mostly parked our program prospectus of the various projects that we've that we were planning on emphasizing this year, which was really overtaken by events with COVID. And at this point, we just want to come alongside our partners because they are experiencing a lot of challenges, just some new costs just to respond to the crisis, and for them to be there for our clients as well. And of course, we're looking at what the program pivot will be when we get through this, how we need to restructure our thinking to, again, partner with the implementing partners that we work with so that we can be there for our clients as they rebuild their livelihoods coming out of this. So it's very crazy time for all of us, but I have been very impressed at the leadership that our partner organizations are demonstrating in each of the countries where they serve. There's a couple of projects that are sort of exceptions to the rule. One is the project in Haiti is continuing, moving forward, and our supporters continue to fund that. Those women continue to be mentored and supported one-on-one, not in group fashion, obviously, but that is a Alter Poverty initiative that's quite important. And the work that we're doing in India in partnership with Opportunity Australia is another example that just actually fits amazingly into this COVID crisis, and our guest will speak to that a bit. And so we're quite delighted to see that project move forward as well. So, without further ado, I'd like to welcome our guest and thank her for agreeing to share with us, because it's actually 9:30 p.m. where she is right now. Jessica Carter is the Director of Opportunity's Asia Health Program, which provides preventative health solutions for 6 million people. She has over a decade of experience in global development, working with communities living in poverty in countries including India, Bangladesh, China, and Papua New Guinea. She's currently based in Hyderabad, India. And Jessica, thank you so much for agreeing to share with us about this amazing program that you're leading and that we're delighted to be partnering with Awaya Australia on. Jessica, over to you.
Thank you so much, Dan, and it really is a pleasure to be here with all of you for my night and your daytime. It's a difficult time for all of us, and so I really appreciate the effort that you've all made to join on this call and this conversation. So tonight I would like to go through a broad overview of what our preventative health program looks like at Opportunity International, particularly with a focus on India. Then I'd like to share a little bit more information about COVID-19 in India, what that means for the Indian healthcare system and what that means for our programs here. And then also finally to touch on where the program is going, what our goals are and the vision for going ahead. So I guess to begin tonight, I'd like to paint a bit of a picture of what the goal of our health program actually is. And, you know, it's very much in line with Opportunity's broader approach, which is around helping to remove the main obstacles that keep people living in poverty. And the health program emerged from many conversations with clients, many conversations with our program partners in the field in different countries where we work, where the message that we kept on getting was that a key obstacle for families to continue living in poverty was their health. Even if they had access to a small loan, if they were unwell or their children were unwell, they couldn't work, they couldn't repay their loan, or their kids couldn't go to school, and so the cycle would continue. And what we see, particularly for people living in poverty, is that the key obstacles to better health are around awareness, access, and affordability. So awareness in a very broad sense, things that we completely take for granted, like at the moment, everybody is talking about the importance of washing our hands. That is a piece of information that for a lot of the communities that we work with, where literacy and education levels are low, that's not information that we can take for granted that they have access to. So awareness is one of those. Another of those is access, and ensuring that people have access to not just health services, but also health products like soap, so that they can actually use that information. And then finally, affordability, and ensuring that the options that people living in poverty have for managing their own health are affordable to them. And so with all of that in mind, the Asia Health Program was developed so that we could help empower clients to build a locally led, sustainable solution to really focusing on the preventable health issues that so many people living in poverty face. About 70% of illnesses in developing countries are preventable. And so we know that if we focus on that sort of combination of awareness, access, and affordability, we really have a good shot of managing so many of the health issues that those people face. So obviously we are interested in improving health outcomes because that's a good thing in and of itself, but also we're interested in improving health outcomes because it's a fundamental component of living a good life and not just surviving, but actually being able to thrive as well. So that's the focus of what we're doing. So I'd just like to give you a bit of an overview now of what the program in India actually looks like and how we're addressing those issues of awareness, access, and affordability. So the Indian program has been happening since 2012, and it's been delivered through a number of program partners. At the moment, those program partners are Healing Fields and Kashpur, who I know some of you on the call met and visited in the states of Bihar and Uttar Pradesh about 2 years ago. And those program partners form a really nice combination. So Opportunity focuses on microfinance. That's the essence of what we do as an organization. One of the things that microfinance offers is a platform of relationships to people who are living in poor communities. And so by introducing the microfinance partner to a health partner, in this case it's Healing Fields, we're able to create a solution that is not only sustainable but is also scalable. And so through the program so far, we've been able to reach nearly 6 million people by leveraging the microfinance platform as part of that. So the interventions that we do are twofold. Firstly, we have a huge focus and the majority of the approach is around preventative education. So we want to make sure that we are providing people living in poverty, both the microfinance clients, their household members and their community members, with access to basic information on health, hygiene, nutrition, sanitation, safe water, topics that are really, really fundamental for those people to be empowered with the knowledge that they have to make decisions that will help keep them and their families healthier. So with the preventative health education, that is delivered by local women, and we call those local women health leaders. And those local women are microfinance clients who have received additional health education and training and are then supported to reach out to at least 200 households in their community. And that's about 1,000 people each. And that grows over time, and some women reach even more than that, but that's the minimum that we hope for them to target with that health education. So through that, we've been able to reach 6 million community members. And that sort of forms the foundation, if you like, for what the health program is and what we're trying to address. The other component of the health program is around health livelihood development. So this is about trying to address those issues of access and affordability. In a lot of the communities where we work, and I'm going to share a story shortly to paint more of a picture, the families that we're reaching really don't have access to the sorts of services that we would take for granted. And that's everything from a hospital to a pharmacy that they don't necessarily have access to. And so we've been exploring ways that we can create livelihoods for the health leaders so that they can continue to earn an income in their role in the community as a health leader by providing additional access to affordable services. And so some of those things might look like the women selling items like soap and sanitary napkins, or it also might look like them playing a first responder or a first aid type role in the community. So with that combination, we're really trying to address those key obstacles to better health for people living in poverty around awareness, access and affordability. And what we've found so far through a number of the evaluations that we've done is that we are really making an impact and we are starting to see changes take place. So as I mentioned before, we've trained 4,500 health leaders in India so far. And those women have collectively reached 5.8 million people. And so that platform of awareness has let us build on additional services as well. So around 25,000 households now have access to toilets or clean water filters, pumps. That number is what we've counted as people who directly accessed those products and services through the program. We think that it's higher than that, but those are the ones that we've counted because they've taken a loan from our microfinance partner Cashpour to be able to build those. We've also got around 200,000 women and girls who are now regularly purchasing sanitary napkins. They purchase them from the health leaders, and the health leaders are able to earn an income through the sale of that item. And about 2/3 of the health leaders have seen their income increase by participating in the program. And that's driven by two factors. One is that the livelihood activities that they're doing are helping them to increase their income. And the other is that they're saving money because they're no longer having to spend additional money on health services that they may previously have spent their money on. And so that's a savings, and that's helped to increase their household income. So I guess to paint more of a picture of this, I wanted to share a story of a woman that I met, and her name is Kumkum Devi. She lives in the north of India, where a lot of our health program is focused. The majority of our health program is really focused on those states of Uttar Pradesh, Bihar and Jharkhand. Uttar Pradesh and Bihar alone collectively represent about 300 million of the 1.3 billion people living in India. And those two states, if you treated the indicators there and you looked at them as countries rather than states of India, you would find that the indicators that they have around health and general poverty and well-being outcomes are some of the lowest in the world. And so focusing our energies on those particular states in India has been really essential to this health program as a way of making sure we are meeting the people who are most at need in this country. So Kumkum is a really typical sort of woman that you would meet. And as I said before, I know quite a few of you travelled with me in end of 2018 to the field and met women just like her. She lives with 7 family members, and some of them are her children, some of them are her in-laws. That's very common for multiple generations to live together in one home. And she runs a tailoring business. So she's a cash poor microfinance client, and she used her first loan to set up a very simple tailoring business, which she's been able to grow over the years. And when I met her, the thing that really struck me about Kumkum was how fundamentally she saw the role of education in her children's lives and also in her own life. So she never had the chance to finish her education. All of our health leaders have to complete up to the equivalent of grade 8, but most of them haven't gone beyond that. That's really common. And so she completed some schooling, but didn't manage to finish all the way through. And so for her, a huge priority was getting her 4 children educated. And 2 of those children are daughters, and she saw it equally as important to educate her sons as well as her daughters. So she signed up to become a health leader, both because she could see the value of that role in her community, but also because she felt like it was a chance for her to continue her education in some way, and because she had not received many opportunities for learning in her life. And so that really represented something to her that enabled her to keep learning and also to be able to be a teacher in her own community and share that information. And that's something that really strikes me, because whilst we definitely talk about the program as having a huge health focus, and we also talk about the livelihoods and the economic elements of the program, actually from a women's empowerment perspective, the program is also really impactful and important, because we are training women to educate their whole community on issues. And often they aren't women who've previously had a voice or who've previously had mobility and the chance to go to other people and other households in their communities and share information. And so for them to suddenly become a source of important and relevant information is really, really powerful. And so that empowerment component is a really important part of the program, and Kumkum really represents that, I think. So as well as training her community on basic health and hygiene education, she's also earning an income through the sale of sanitary napkins. And she has also been earning an income by encouraging people in her community to access, who are existing microfinance clients, to access loans from Cash Poor to build toilets. And so she receives a small commission for doing that. And then the community members have access to a household toilet, which is really important because a lot of community members don't. So I just wanted to share her story very briefly to, I guess, give a deeper insight into the sorts of women that the program is helping. And of course, behind her is a family of 7 people and a community of, at least 1,000 people that she's also reaching and working with as well. So moving from there, I guess I'd like to sort of talk a little bit more in detail around how the program is operating at the moment in the context of COVID-19. Probably we could have made this whole discussion tonight just about that. It's the thing that everybody is thinking about, and everybody is wanting to know more around what it means for ourselves in our own communities, let alone what it means for people who are already vulnerable and already living in extreme poverty. In India at the moment, so I'm in Hyderabad, which is sort of, if you look at a map of India, it's right in the middle. In India, the situation at the moment is that we're under a national lockdown. And so what that means is that we are not able to leave our homes. Essential services are technically allowed, but as you can imagine, in India, that doesn't necessarily mean that they do still continue to be possible to access. And so India has seen, when we started lockdown, we were at just over 150 cases. We're coming into the end of week 2 of lockdown now. And we're now at about 5,000 cases. So we really hope that the decision to lock down the country has helped to flatten the curve, so to speak. But unfortunately, a big part of the challenge here is that a national lockdown for you or I might be reasonably straightforward, and it's inconvenient because we have to stay at home, and it's, it's not the best thing in the world because maybe you can't exercise outside as you normally would. But in India, for a lot of people who are already living below the poverty line or are close to the poverty line, it's fairly catastrophic, because they aren't in a position where they can stockpile food, and they aren't in a position where they can necessarily access the sorts of basic essential items that they need on a regular basis, let alone during a lockdown where everything is logistically more difficult to get to. And so there is a lot of concern here in India that not only will COVID-19 bring considerable challenges from a public health perspective, it will also unfortunately bring considerable challenges potentially from a humanitarian perspective, as the lockdown means that people can't work, but they don't have the sorts of safety nets that we have in our countries in order to be able to get through this period. So the Indian health system is fairly fragile to begin with. There's, as I mentioned before, a lot of the health challenges in India are certainly concentrated in the north, in the states where we operate. But even if you zoom out and you look at India as a whole, the healthcare system in India is not one that serves all citizens equally. And so if you have a lot of money, there are absolutely private healthcare options for you to access. But for the overwhelming majority of people, middle class and below poverty line people, those are not affordable options. And so the pressure that we're seeing on really strong healthcare systems like Italy and Spain is going to be even greater here. In the city of Hyderabad, where I am, I think that they say that there's about 30 ventilators in the whole city, and Hyderabad's a city of 10 million people. And those will be accessed by people who can afford it, not by the general population. So there's a lot of issues. And I guess that comes back to why something like the prevention program that we're already doing is so essential. Because what it means is that in the villages, where thankfully we have not yet started to see outbreaks of COVID-19 in the same way that we've seen them in urban centres like Delhi, Mumbai, Hyderabad, in the villages, if we can share information that is helping people to understand what the illness is, to identify it, and understand when they need to seek help, we have the best chance if we focus on that prevention. And so the program is really set up to be able to provide information and access to care for the most vulnerable people and the people who might not be able to access the same sort of information that the rest of the population is able to access. So already before lockdown, the health leaders had started mobilizing their communities with education around COVID-19, providing information on what it is, the sorts of symptoms to expect, also doing hand washing demonstrations, as well as providing communities with seeds so that they can start preparing kitchen gardens to continue to access nutritious food during this period. And so that thankfully was able to continue before the lockdown started. Now that we're under the lockdown, those activities have shifted slightly. Obviously, the health leaders still have access to the people in their villages at a very localized level. And so we are exploring how they can use platforms like WhatsApp or other technology-enabled communication devices to be able to continue communicating with their community members around COVID-19. So if we can focus on prevention in the first instance, as well as utilising the health leaders for detection, so helping them understand how to identify community members that may be possible cases for COVID and referring them to get testing where possible, and using technology, voice-enabled response messages and things like that to be able to do so. Another really important role that the health leaders can play is in being in the communities and setting up isolation centres so that someone who is identified as having symptoms is able to be placed under quarantine and monitored under quarantine, and they can play part of that role. So one of the things that you might have seen on the news is that with the news of the lockdown, a large number of India's migrant workers who typically might be working on building sites and things like that in a city like Delhi, suddenly with the announcement of the lockdown, they had no buses to get back to their villages, but they didn't have stable housing in the city in the first place, and suddenly they definitely didn't have an income for the next 3 weeks. So we've seen thousands, if not hundreds of thousands of migrant workers walking hundreds of kilometres back to their villages. And of course, those people are unfortunately at risk of carrying COVID-19 back to those villages. So the isolation centres can play a really, really important role there. So the health program is really well positioned to be able to address the issues of prevention and detection particularly, and where possible to refer people to the existing healthcare system. But ideally we will be able to share information with the community members so that we can mitigate the spread as much as possible, obviously in the wider context of everything else that the country is doing. And of course, what's really, really important is once we get through all of this, we need to keep building the platform of health leaders that we work with. We need to keep scaling that. We need to keep ensuring that that's a platform that is sustainable, because I think if nothing else, this experience is showing us absolutely that prevention is better than the cure. And the investments that we make in our health systems today will absolutely pay off tomorrow. So continuing to build the cohort of women and to train more health leaders so that they can train their community members is really, really important. Having information being shared by locals is really, really powerful. We all know that we're more likely to listen to our peers. And I think particularly in the context that we're working in India, that's even more important here. And so really mobilizing those women, continuing to train them, continuing to support them so that this is a long-term platform that's not only addressing COVID-19, but the many, many other preventable illnesses that are already issues in the community here, like typhoid, cholera, malaria. These are all things that we still need to keep preventing alongside COVID-19 as well. And so I guess what we really want to be able to do is to keep supporting those health leaders in their particular role in prevention and detection in the communities right now, as well as training more women like them for the long term so that we do have a really meaningful platform that we can leverage when other health crises inevitably come up. So our goal in India is really focusing on deeper impact and greater reach. And over the next 2 years, we would like to be able to train a total of 4,800 health leaders in total. So that would mean reaching at least another 400,000 people. As I mentioned, that's absolutely got to be a locally led and sustainable solution. We know that what we're really trying to do is to change behaviours. And so it's really, really crucial that that is both locally led and long term. And as I mentioned, it's really about focusing on prevention, focusing on building local knowledge, and coming back to awareness, access and affordability, which I think it's evident in the current situation is more important now than ever. And the really good thing is that it's incredibly cost effective. So $1,000 is enough to train one health leader and she'll reach about 1,000 people. So you're looking at about $1 per person reached with health education. And we know how powerful that is. We've seen the impact that that's had on maternal health outcomes in communities, on outcomes around children and outcomes around nutrition, basic hygiene, sanitation, menstrual health. And so we know that it's an incredibly powerful solution and platform. And I think that at the moment we can see just how essential it is. So I guess that probably draws me to a close. I'd love to answer any questions that people have and go into more detail on whatever it is that you're interested in.
Well, thank you, Jessica, for that excellent and inspiring presentation. As I said at the outset, Opportunity Canada has decided to partner with Opportunity Australia on this project. And in fact, I've got the project prospectus right here, which I said has largely been overtaken by events, but you can see the India section right there where we are in fact committed to this project. We have wonderful supporters across the country who have really been moved to be a part of this. And so we will continue to support it. I want to congratulate you and your colleagues on being so innovative. You know, it's amazing how microfinance as a concept can broaden beyond the amazing thing it does with one entrepreneur at a time into specialized areas like education finance or agricultural finance, and now into the health sector, where it changes lives and also provides a sustainable income for those involved. It's an amazing concept that you guys have pioneered, and we're really delighted to be a partner of that. As Andrew has been saying, if we have questions, use the Q&A button at the bottom. We have some time here, up to the next 20, 30 minutes to take your questions. So by all means, send them in. And Andrew's going to moderate as these questions come in. So Andrew, what have we got out there?
So one question was, you mentioned, the one question is, how long has the health program been running to reach the 6 million people impacted so far?
Yeah, so Opportunity started funding the health program in 2012. That came after a 2-year pilot between Cashpour and Healing Fields, but the scaling didn't really begin until 2012. That's been across multiple partners. We've worked with 6 microfinance partners in India, as well as Healing Fields providing technical help assistance.
Okay, another question has come in. Can you talk more about the path to sustainability with this program? Thinking more on the financial model side of things related, I would love to hear more about other business opportunities that could exist within health beyond the great start with the sanitary napkins and toilets.
Yeah, sure. So look, this has been a really big focus of the program, particularly in the last 2 years. What we found is that the health leaders who are supported initially for a 12-month period, 6 months where she does training and then 6 months where she's educating the community and receiving a stipend for that. After that 12 months, so many of the women continue providing health education in their communities, even without that stipend. So we've been exploring how we can support them financially beyond that period. So the things that we've tested have included 3 things. Firstly, we've actually been able to continue supporting a large number of the health leaders to continue receiving a stipend to continue delivering refresher training or extra training to additional community members. And that stipend has been paid for by the microfinance provider itself. And so that's been a really, really powerful way of, really making the most of the role of those health leaders and ensuring that they're sustained in that ongoing education role in their communities. The other 2 things that we've been testing, and this probably is more at the heart of a business model around it, as your question mentioned, is exploring how can we monetize the role that the health leader plays in the community through the sale of either products or services. And so we've developed what we call the health entrepreneur model. And so that's where we're trying to test these 2 ideas. So those are, if you like, graduated health leaders who've done additional training, basic entrepreneurial skills, and those women have access to a suite of products, a product basket, and are earning a small income as a commission through the sale of those. So the items look like soap, sanitary napkins, toilet cleaner, dishwashing liquid, mosquito repellent, and the mix of products, figuring out the price point to sell it at, figuring out the supply chain behind all of that, has very much been where our energy has gone over the last 2 years, because we're trying to get these products to last mile communities where other logistics and big companies won't go. And so figuring out the supply chain and the price points around that has been where our energy has gone. We've had some success with some products. Sanitary napkins is one of those. Soap is another one of those. But we're still sort of getting the product mix right to make that meaningfully sustainable, that we can really scale it. We're still learning and seeing what we can do there. And the other thing is looking at how we can support the women to earn an income by providing health services. So some women have also done additional training in first aid and basic diagnostics. And so those women are able to use technology, a tablet application that helps them do a basic diagnosis of the women, and if necessary, refer them on to a doctor. And so those women are then receiving a fee for that work. So we're exploring the products and the services roles. And what we hope is that once we get the mix right, both with what the women want, what the community members are prepared to pay for, and what we can access through the supply chain, that we can begin to scale that.
Fantastic, wonderful. What surprises, positive and negative, have come out from the project that can be viewed as key learnings?
Yeah, sure. I think I touched on this slightly earlier, but for me, I guess something that was a surprise at least a few years ago, was when we did some of the impact evaluations and really did see just how much of an impact this program was having on women's rights and women's empowerment. Obviously, we designed the program so that it would focus on health leaders who are female microfinance clients, because we wanted to be able to influence those women, because we know that they are the key decision makers around healthcare in their household. It's them who makes the decision of what food to put on the table, what soap, if any, she's going to use and buy at the markets for her family, whether or not her child gets to take a day off school if they're sick, or whether or not they're going to go to the hospital. And so we focused the program on women for those reasons. But what we also saw was that the increased mobility that came with the program, because those women suddenly had a reason to go out of the house, to engage with other households in ways that they previously didn't. And suddenly they also had an elevated position in the community as leaders. We suddenly saw the impact that that was having on their empowerment. And also the shift in perception from men in the communities as well. And seeing them transition from being unsure about the role of the women to being very supportive of those women as they saw the impact that they could have on the health of the community. So that's definitely been a really nice surprise. A negative surprise, look, I think, to be honest, one of the biggest challenges has been, as I just mentioned as well, the logistical challenges of building a supply chain in communities where people can't afford very much. So we have scale, so we can build a supply chain around volume, but demonstrating to companies that are providing essential products that there is a market there is a bit of a chicken and an egg situation. And that's absolutely been one of the things that we've really been working through in the Health Entrepreneur Program, and something that we continue to work through and learn about. And I hope that we can find a way forward and prove some of those organizations wrong, that there is absolutely a market there if they're willing to go to those communities, and that it's absolutely a great thing to do.
That's wonderful. Now you touched on this at the end, but one of the questions is to go back to the COVID aspect, how has training for the healthcare leaders been adapted for the COVID-19 pandemic, if at all? So has it been adapted?
Yeah, so the training itself was adapted about 6 weeks ago now, when the health leaders began providing additional content focused specifically on COVID-19. So it was basic awareness about the illness itself, but then also, as I mentioned, focus on looking at sort of prevention activities that are essential to go alongside that. So increased focus on hand washing demonstrations, and an increased focus on nutrition, because we know that keeping the community members with access to basic healthy food is really, really important for them to keep their immunity high. And so the program has been adapted in those ways. In terms of what it looks like right now, because we're in week 2 of a 3-week lockdown and we don't know necessarily how long that will continue for, we are exploring ways to continue providing that education to the women through technology. And we are also utilizing those women as health leaders in the communities to support some of the existing efforts around building isolation centres, using some of the government funds and working with government organisations to be able to deliver the services to the communities themselves, because often the bureaucracy stops at the edge of the village, and you still need relationships within the village to get things done and to coordinate logistically and make sure everybody is getting access to food rations, for example, if the government is providing those, or that the isolation centre is actually being utilised appropriately, and that the people who put into isolation don't just walk out in the middle of the night. So that's the kind of detection role that the health leaders can play that's really important, as well as adapting the content to focus on the prevention aspect as well.
Oh, Dan, I think you're trying to talk.
We have another question here, and that is that just wondering what mandate from the government towards the local microfinance institute partners have come down in terms of loan disbursements and that can, and you know, the ability to access loan, any changes with as a result of the shutdown that might be impacting ability of clients to pay and that sort of thing. Has that begun to be a factor in India?
Yes, it has. So obviously being under lockdown, no businesses can operate unless they're deemed essential services. Microfinance institutions are not deemed essential services. So what that means is that at the moment, all loan disbursements and loan repayments are on hold. What we think is probably likely is that there will be state level directives to the community that they can not make their loan repayments. That's happened in the past. It's a really political issue in India. Often right before election time, politicians tend to announce to communities that they don't have to repay their microfinance loans anymore. And whether or not that's legally enforced, the consequences are pretty catastrophic because it means that people don't repay, and that puts the microfinance institutions in a really vulnerable position. Equally, even if that doesn't happen, the fact that nobody's getting any income and can't work at the moment means that a lot of clients are going to be in a really challenging position to repay anyway. So look, because we're, as I said, in week 2 of 3 of the lockdown, and we don't know yet whether that will be extended and for how long and what that looks like, we're really still figuring out what that particular impact is ultimately going to look like. But yes, we expect it to affect microfinance activity significantly, both in the present and therefore in the longer term, as those organisations and communities try and respond and recover. And what we know is that we really need to be there for the long term with the microfinance partners and the communities that they serve, so we can make sure that this disruption doesn't limit their business activities once we get through this.
Thanks. And I think that response applies pretty much to every country that we're working in right now. There's a fairly interesting sort of data technology type question here that I think you'll find maybe challenging, but I'll say that, you know, it reads as follows. You mentioned some pretty impressive improvements with growth after the health leaders started in an area, but have you set up any controlled groups for comparison, like say matched demographics or that sort of thing, that you can then leverage and demonstrate to others? Or could some more controlled comparison data sets be useful for solving the chicken egg issue you described with product companies and supply chain?
Yeah, so great question. So actually the most recent evaluation that we did of the program, which was end of 2017, was actually a case control study. So we did have some control groups where we identified community members that were very similar to the conditions and the demographic of the health leaders and the community members being reached by the health leaders. And we tracked those communities over 6 months. The sample size that we had, I can't remember off the top of my head, but it was a very reasonable sample size. And that's where we have got a lot of our data around the impact that the women are having, and why we do have confidence in some of those results that we've been able to see around the impact of those women on really genuinely changing not just health knowledge, but actually health behaviours, because the goal is not just the information, it is actually the behaviour that needs to come with that. So not just knowing that they need to wash their hands, but actually washing their hands, not just knowing that a toilet is useful, but actually using that toilet. So through the case control study, we were able to demonstrate that. To your point around using a similar sort of methodology for addressing some of the supply chain issues, look, definitely yes. To date, we haven't done that. And that's because we're 2 years into a pilot where we are exploring what the most appropriate options are, and probably taking more of an adaptive approach where we're responding to what we're learning as we go based on what's available in the market. We began the Health Entrepreneur Program with market research. That was what we based a lot of the decisions on for that program design. Honestly, one of the biggest limitations to doing a case control study until there's sort of enough of a cohort of community members participating and enough of a reasonable body of evidence of learning from the program is the cost. The cost of delivering a controlled study can often equal or be greater than the actual cost of delivering the service to the community members themselves. So we obviously have to make a decision around which is going to have the greatest impact, and what is going to be best use of funds spent. So hence, we haven't yet done a control study for the entrepreneur component specifically, but down the track when we get to that point, that might be a really great approach as well.
Another great question I think that came in is, has the health program been able to leverage any partnership opportunities with Opportunities Education Finance Initiative? Has this connected with the schools?
So at present, the answer is no, but there's opportunities down the track, I think, that we can explore and that we have certainly been in conversation about. So the community health education model has also, I guess, recently started working with schools, where the health leaders are able to provide community education to school students, and they're training school students to be basic health champions in their school, just as those health leaders are in their community. And that's a really powerful way for the health leaders to continue educating larger groups of the community, but also actually the health leaders are paid a fee for that. So that's another great source of income for them as well. That particular adaptation of the program is still in its early stages, but we have definitely seen some success where it has been tested so far. So it would be really fantastic one day to explore how we could utilize the school's platform through education finance and connect that geographically with the health leaders, and use that as a sort of network for those health leaders to work through, in the same way that the health leaders use the microfinance network. So absolutely, that's something that we hope will come together in the future once EduFinance has more of a footprint in India, and as we are able to refine the school's education model as well.
Muted. Thank you for that, and those are some excellent answers. One thing I think is ironic, perhaps, in the context of the struggle we have right now, is that today is World Health Day, which we were quite excited to bring you on for World Health Day, since this is a health initiative, but it's all the more appropriate now given the obviously health and related economic challenges that we're all facing, and our clients and partners are going to be facing with this COVID crisis. You've answered I think all the questions with excellence, and I'll kind of throw it out there one more time. Andrew, any other questions that you can see or that you yourself have?
Personally, one question I've been challenged with is just wondering how the men are adapting to seeing these women leaders in the community. But they're getting quite a strong role in how our men in a society where women might not have such a strong voice typically. How are the men adapting to that?
Yeah, sure. So look, certainly what we've seen is that at the beginning of introducing the health leader training into the community, there can be quite a bit of resistance from either the husbands or the fathers-in-law or even the brothers-in-law of the health leaders. And that has absolutely been an issue in the past. But typically what we find is that if we can persist and if we can support those women through that period with education, but also, giving them the support that they need to manage their family's expectations, that eventually there's two things that convince the men that this is a worthwhile activity. And the first is that it saves them money if they start seeing that their family is healthier, if their kids aren't constantly sick with diarrhea and they're not spending money on going and buying things to make the kids better, or they're spending less money because they know how to filter the water themselves. That's a huge advantage. And then the other factor is that often if the men themselves are able to be treated for a particular health issue and they see that that has made them better, then that usually wins them over. So I often think about a woman that I met who she had a husband who was not very supportive of her role as a health leader. He was a migrant worker working on a building site in Delhi. And one day he came back to the village. She'd sort of been hiding her role as a health leader from him because he hadn't shown a lot of support. He came back and he had a really significant wound on his leg from an injury on site. And so she convinced him, firstly, that they would go to a hospital, which he wasn't happy about, but they did that. They were able to treat the leg. The doctor thanked her for bringing him in. in. And then they needed to keep dressing the wound every couple of days. And either they could go back to the hospital to do that, which would cost them money every time, or his wife, who had trained as a health leader, was able to do it for him. And because she was able to do it for him, and because that was saving money, and because he could see that it meant that his wound healed and he essentially was much better off than he would have been otherwise, he was convinced. So lots of little examples like that we see, where it just takes people time to adapt to an idea and to adapt to a new practice. And if they see something's in it for them, especially if it's financial, then they tend to get on board. And honestly, across the board, as the health program has grown as well, there's been really good word of mouth and reputation that's gone with it. And I think that that's particularly helped a lot of the newer cohorts of health leaders too.
Thanks, Jessica. And that is the story of microfinance over the last 50 years, isn't it? And empowering women, and, you know, obviously the challenge they have, but as they, you know, have this financial independence and can provide for their families, it becomes very compelling. Question that's come up is how can Canada best stand with you and your colleagues? How can we be an encouragement to those you're working with, especially at this difficult season?
Yeah, look, I mean, I think that, and in a time like this, we all need to stand together. And I think both us as me as an Aussie and you guys as Canadians, but also obviously with the people that we serve in the countries where we work, not only in India, but in all of the countries where Opportunity works. I think it's about standing by to listen to what the local communities are saying that they need at this time, and also very much being there for the long-term recovery. Right now, we're all very focused on the immediate response to COVID-19 and what this means. But really, the best investment I believe that we can make is the long-term investment in healthcare, and with a focus on primary health, preventative health, and really ensuring also for our microfinance partners that we're there for the long term so that they can keep serving clients, and that we don't see a collapse of the great services that they already provide after all of this ends.
Well, Jessica, you and your partner are certainly in our prayers, and I know that you're staying in India during this time, and you know, it's obviously not without its challenges. So we just want you to stay healthy and safe, and thank you for the leadership you're providing to this amazing role, and thank you so much for being willing to join us today. I think that's pretty much the end of the questions, so we'll probably get to the end of our session here, but wish you a very good night. And I just want to say for the rest of you that next week is the 4th in our series of town halls, and we'll be featuring Andrew McCusker, the director of our education finance program globally. And as you can imagine, the COVID crisis has shut down schools, and there's something like 1.8 billion kids out of school around the world right now. This has had a massive impact on education finance, education quality programming, and there's some fairly innovative responses as how they're going to move forward there as well. So once again, Jessica, thank you so much, and we wish you all the best, and I wish you a good night, and thank you for sharing with us. We just very much love our partnership with you and with OI Australia on this amazing program. So, God bless.
Likewise, thank you so much.
And thank you to everyone for joining us, and we'll see you again next week on the next town hall. God bless.